This is the Best Health Podcast, brought to you by Wake Forest Baptist Health in partnership with MedCost.
Good day, everyone. Welcome back to the latest episode of the Best Health Podcast, brought to you by Wake Forest Baptist Health in partnership with MedCost. We really do appreciate you taking time to listen to the latest episode. As with most of our episodes, we try and provide valuable information about the health and wellness area and how we can help you be as healthy a person as you would like to be through your life journey. Now, we have a really interesting program lined up for you all today, and I hope you take time to listen and maybe jot down a couple of notes or pass it along to a friend if you find it informational. And before I do jump in with our special guest, I just do want to remind everyone that our podcasts are available wherever you will download your podcast in your respective podcast stores, if that's Apple or Google Play. Also, they're available for listening on our website at wakehealth.edu/podcast. So moving back into today's programming, two great guests. I've known one of them for a good bit now and excited to meet the other one here and talk about reproductive medicine and how some of our experts here at Wake Forest Baptist Health can talk with patients about that topic and how they can learn more and how you all can learn more. So what we have in store is Dr. Jeffrey Deaton. He is the section head for reproductive endocrinology and infertility, better known as reproductive medicine. So welcome, Dr. Deaton. How are you, sir?
I'm doing well. Thanks for having me.
Of course. We're very excited. I know how busy you are, so we're very excited to have you as a guest on the Best Health Podcast today. And joining you is one of your colleagues, Dr. Shelby Neal. She's an assistant professor in reproductive medicine as well. So welcome, Dr. Neal. How are you doing?
Doing well. Thanks so much for having me today.
Of course. I know y'all have a lot of great information to share. And if I'm not mistaken, we're celebrating a little bit of a milestone here, Dr. Deaton, aren't we?
We are, and it's so exciting because the program started 30 years ago about this time.
Wow.
Our very first conception was 30 years ago in December, and so we're kind of celebrating a milestone because back in that day, there weren't that many programs in the country. We were one of the earliest ones, so we're excited about the milestone.
That's really interesting and really cool, to be quite honest. We'll get a little bit more into that here in a second. But before we do, I'd love for y'all just to tell a little bit about yourselves and how long you've been with Wake Forest Baptist Health and what got you into this area of medicine and any other interesting tidbits you want to share with our listeners. So Dr. Neal, if you want to go first, that'd be great.
I'd be happy to. So I was born and raised in Baltimore, moved to North Carolina to attend Duke for my undergraduate education. I studied engineering, spent a year doing research in an arthritis lab actually prior to matriculating at UNC for medical school. During medical school, it became clear that I was really interested in women's health, and I elected to pursue residency in OBGYN at the Medical University of South Carolina in Charleston, where I fell in love with the subspecialty of reproductive endocrinology and infertility. I went to New Jersey, where I trained at Thomas Jefferson RMA, New Jersey, for my REI fellowship training. Okay. And this is my first position out of fellowship. I have now been here at Wake Forest for a little bit over a year. And I have, been very privileged to join a team consisting of Dr. Deaton as well as Dr. Bruce Lessy, our other partner, and a great staff here at the Center for Fertility, Endocrine, and Menopause. And I'm really excited to give you a little bit of insight into what we do here every day.
Outstanding. Thank you for sharing. And I hope you are, after being here for about a year in this part of North Carolina, settled in and found your favorite restaurant or hiking trail to visit when you have some free time.
Yeah, absolutely. This is a lovely place to live.
Great. So Dr. Deaton, you're up next. Tell us a little bit about yourself.
Yeah, so you just heard from sort of the younger person in the practice, and now you get to hear from I'm not going to say older, I'll say the
seasoned, more
mature, the seasoned person in the practice. Yes. That's a good way to say it, seasoned. I like that. So I came here in 1990. I finished my fellowship in June of 1990 and was recruited here as my first job to start the IVF program. And so I'm actually just finishing my 30 years too. But I took 10 years off and went into private practice. It's a long story. It's not that important for why, but I left in 2006 and went over into the Greensboro market for private practice. Mm-hmm. And I did that for 10 years, had a great time, but was lured back to Wake Forest in 2016. And I'm very, very happy to be back. I did my medical school and undergraduate at Vanderbilt. And at that time, I grew up near Memphis in Tennessee and did my, like I said, undergraduate and medical school at Vanderbilt, and decided I needed to branch out and kind of see the world. And so I went all the way up to New England for my residency in Connecticut. And then I did my fellowship in fertility in Vermont, which I finished in 1990. Okay. I think that's a basic introduction. I do have both a biologic son and an adopted son. So I do bring a little bit of a different perspective to some of the couples that are struggling with even whether to be treated or not, and to talk about other aspects of kind of growing your family.
Sure. Well, that is informational. We appreciate you sharing as well, Dr. Deaton. So if you all wouldn't mind, just before we dive into more specific medical type questions, just for people listening to this podcast episode, I know that some people might have more of a base of knowledge than maybe some others about the area of reproductive medicine, but just a maybe quick snapshot of patients who are coming to see you in your clinics. What is the basic function and purpose of you all in your area within Wake Forest Baptist Health as far as helping patients meet their goals? And Dr. Neal, I'll throw it to you first, and then Dr. Deaton, you can add on if you'd like.
Happy to address that. So I would say that the bulk of the patients that we see are coming to us for infertility. They are trying to conceive and have not been successful in conceiving on their own, and so are seeking evaluation and treatment of their fertility. We do, however, have a handful of patients who come to us for management of their reproductive endocrine disorders, things like PCOS, thyroid disease, hyperprolactinemia, and others. And then we take care of patients also who are not infertile, but maybe have underlying genetic disorders for which they are seeking to undergo IVF in order to prevent transmission of genetic disease to their offspring. And so that is also a unique population that we deal with. And then lastly, we deal with a lot of women who are not infertile, but are seeking to preserve their fertility, either because they would like to postpone having a family until they are older due to career or other personal reasons, or because of a recent cancer diagnosis, knowing that they are facing treatment which could impact their future fertility and wanting to explore options for preserving it from that standpoint.
Okay. Anything to add, Dr. Deaton, or is that good?
That was a great answer, and I would not want to add too much, but I will say one of the reasons I like being back at Wake Forest is that we have wonderful partnerships with, for example, endocrinology. We have a great partnership with male infertility specialists. We have a great partnership with a reproductive psychiatrist. So I like to think of our center as kind of a place where you can come meet all of your fertility needs and all of your female reproductive endocrinology needs, because we handle a lot of that. But if we get to a place where we need some help, we have great partnerships with other people in the institution that do that kind of stuff too.
Okay. Well, Dr. Deaton, I'll just follow up with another quick question here. Speaking of infertility, from a clinical standpoint, how do you define infertility? And how would you say, how common is it among our population here in this part of the country and nationwide?
Well, the official definition of infertility is for women 35 or younger, 12 months of attempted conception without success. That's the official definition. When women get over 35, we shorten the time frame because time becomes important. And so women over 35, we say 6 months of attempted conception with no success. That's technically infertility. if you look at how common it is, it's extremely common, and you would never know it because people don't talk about it a lot. Women who are struggling to get pregnant or couples who are struggling, they often kind of keep it to themselves. But roughly 1 out of 7 women who are in that first age group, 35 or younger, 1 out of 7 would be defined as infertile. In the 35 to 40, it's 1 out of 4, and in the 40 and over, it's 1 out of 3. So it's extremely common, especially as women get above 35.
Okay. Dr. Neal, I'll follow up with you, and you might get some interesting both questions and responses around this area. I guess maybe, because the woman is the sex that is carrying a child and gives birth, maybe the assumption might be that, if a couple is having issues with becoming pregnant, it might be something to do with the woman's body. But you all talk with and are offering services for men and women. So is it usually the women's issue on the fertility side or the man's issue? And how do you go about determining that?
You're correct in that it is a common misconception or assumption that it must be something going on with the female partner. But about 40% of the time, there is actually a male factor component to infertility. And in many cases, the underlying cause for infertility is multifactorial, meaning that there could be both female and male reasons underlying why that particular couple has had difficulty conceiving. And so when a couple struggling with infertility comes into our clinic, our goal is to conduct a comprehensive infertility evaluation, regardless of what is already known or not known about risk factors and possible explanations for infertility, because oftentimes we will uncover more than one reason.
Gotcha. So speaking of reasons, when you all are discussing with patients in your clinic and coming up with solutions, over the years, what have you all found to be some of the more common quote unquote causes of infertility that you can provide solutions for with your patients? Dr. Deaton, I'll let you jump in.
Yeah, Justin, I will get to that, but I want to add one thing to my last answer.
Yeah.
And that is that for your listeners, if there's a clear reason why you're not getting pregnant, don't wait the 12 months. In other words, if the woman's not having periods, don't wait 12 months of that. There's a problem there. Come see somebody.
Okay.
If your partner's had a vasectomy, don't wait 12 months. So if there's a clear reason for it, you don't have to go through that official definition. Now, getting to the question you just asked about the common causes, the workup of infertility has changed dramatically in the past 30 years.
Sure.
And so now we kind of do 3 to 4 simple tests. And I would say the vast majority of people, something will show up in one of these 3 to 4 simple tests. So first, we always check to make sure the woman is ovulating normally. Obviously, to get pregnant, you need to release an egg. And about a third of our women in our office don't ovulate. They don't release eggs. And so we always check to make sure, are you releasing eggs? The second thing we do early on is check a sperm count. As Dr. Neal just said, 40% of our couples, there's a male factor. And so we don't ever miss that. Thirdly, we always do a test of egg number. So women are born with a certain number of eggs, and over their reproductive life, their egg number slowly drops. And when you get down to low numbers of eggs, the quality is not very good. And so we always do a test to check for egg number, and that test is called AMH. It stands for anti-Mullerian hormone. And then if all those tests look really good, we will often do a fourth fairly simple test called a hysterosalpingogram, which is what we call the HSG. Patients know of it as the dye study. And that's the test to make sure the uterus is normal and the tubes are open.
Okay.
And if you do those 4 tests, you'll find a reason in the vast majority of couples, and then you can begin to tailor your treatment based on what you find.
Gotcha. That's great info. So Dr. Neal, to follow up on that information Dr. Deaton just shared, if a woman is concerned about her fertility, what should she do? Dr. Deaton mentioned a minute ago, maybe some women might be a little apprehensive about sharing that information. But what should they do, and who should they contact, and what's the best course, the initial step they should take to learn more about maybe an issue with infertility?
I would encourage any women who are concerned about infertility to have a conversation with their OBGYN. Oftentimes this is something that might emerge at the time of an annual exam, but certainly women don't need to wait until their next scheduled annual exam with their OBGYN. They can certainly reach out to discuss fertility concerns sooner than that, and our referring providers in the OBGYN community are well versed in the definition of infertility and when referral is appropriate, and can certainly help to guide that patient to us as needed. I also think that it's important to point out that women can come directly to reproductive endocrinology and infertility. In situations where that might be appropriate would be if they have been trying to conceive without success for 12 months. In that situation, an evaluation and likely treatment is warranted. Other reasons, as Dr. Deaton alluded to previously when he was discussing the definition of infertility, would be if a woman doesn't have periods, or if a man has a history of a vasectomy, or if either partner has a history of chemotherapy or radiation or other treatments in their past which may impact their fertility. It's very reasonable and appropriate to schedule a consultation with one of us.
So I guess to take a step further, Dr. Deaton and Dr. Neal, a lot of people listening probably have heard of IUI or IVF as far as possible treatment options for infertility. Dr. Neal, if you wouldn't just mind sharing briefly, what's the main difference between the two, and how do you go about suggesting one procedure over another with patients?
Be happy to address that. IUI and IVF are both treatment options that we offer at our center, and we have women going through these treatments every day. IUI stands for intrauterine insemination, and this is a procedure whereby sperm from either the male partner or a sperm donor is washed in our laboratory, and only the motile sperm are then placed directly into the woman's uterus at a time when we know she is fertile, thereby minimizing the distance that the sperm have to travel in order to make it to the fallopian tube, which is the site where fertilization occurs. And generally speaking, success rates with IUI range from about 15 to 20% per cycle. So it's not uncommon that a couple who elects to undergo IUI may need to do a few treatment cycles to have a success.
Gotcha.
IVF is another treatment option. It stands for in vitro fertilization. It is a more advanced treatment option whereby the female partner undergoes ovarian stimulation with injectable medications for a period of about 10 to 14 days. And that process is designed to help a woman create mini follicles in one cycle, with the overall goal being for her to undergo a procedure called an egg retrieval, where the eggs are actually extracted from the ovaries and then fertilized in our lab by either partner or donor sperm. Hence the name in vitro fertilization, because it is occurring in our lab. And then we grow the fertilized eggs out to become embryos, and we can then select an embryo to replace back into the woman's uterus. And success rates with IVF are dramatically higher than with IUI in most cases. It is a little bit dependent on patient-specific factors, but generally speaking, we're talking about success rates in excess of 50% per cycle in most age groups. And so it is our most successful treatment option available, but it is time intensive as far as the number of visits. There's a lot of injections, procedures, and it comes at a higher cost than IUI. And so not everybody will elect to go with IVF, at least not from the beginning.
Gotcha. Okay, so for women listening, Dr. Neal and Dr. Deaton, you might speak to this too, because you've possibly seen the progression of medical technology over the last 30 years. But when someone comes into the clinic for one of these procedures in this time and age, it is they don't have to stay for a really extended period of time. It's not inpatient. If someone comes into your clinic for one of these procedures, could you maybe just talk briefly about what they would expect and the duration they would maybe need to stay in your clinic?
Yes. So when a female partner comes into our office for an IUI, typically her male partner will come in advance to provide a sample. Then our lab takes about 30 minutes to process that sample. And then the female partner's visit is approximately 30 minutes in duration. The actual procedure, the IUI, really only takes about 5 minutes.
Wow.
And so typically a woman would be in and out of our office within 30 minutes. There are no real restrictions following an IUI. So a woman can return to work, go about her daily activities that day. Our goal is really just to make it like a routine doctor's visit, and in some cases even quicker, just because they have been coming to our office frequently, and we want to make it as seamless as possible. As for IVF, when women come in for the egg retrieval, which is the big procedure that all of the medications are leading up to, they can expect to spend about 2 hours at our office. The procedure itself takes about 15 minutes, but there is anesthesia for the procedure. We provide IV sedation. We have anesthesia providers who take care of that for us. And because of that, we do like to monitor patients afterwards until the anesthesia wears off a little bit, and we can confirm that their pain is well controlled, and they're not having any peri-procedural complications before we send them home. And so that is more of a 2-hour experience. And typically patients will rest at home for the remainder of the day. There's no operating a vehicle or going back to work because of the anesthesia that they've had. But most patients will actually return to their jobs the next day and essentially most of their typical activities, with the exception of intercourse or strenuous exercise.
Thanks for listening to this episode of the Best Health Podcast, brought to you by Wake Forest Baptist Health. For more wellness info, check out wakehealth.edu/besthealth and follow us on social media. Wake Forest Baptist Health. Care for life.